Now coming to the GDM, gestational diabetes mellitus. Why are we so worried about GDM? Because we are worried about all the problems which can happen with GDM in the pregnant woman. It can affect the pregnancy and the outcome of the baby. See what happens, sometimes we all know about the polyhydramnios, we know about the macrosomias in the baby, we know for the larger than gestational age baby, the big babies which happen with the diabetes mellitus. And because of this macrosomia, these big babies, we are worried about the outcome. And unfortunately, if the woman had gestational diabetes, which was not corrected in the preconception period, and the incidence of congenital anomalies are also very high in GDM. So these are the reasons why we are worried. We would definitely not like a woman to have a baby with an anomaly. We wouldn't like to have a mother with an macrosomic baby. What happens? And sometimes these women we find are more prone for the other problems in pregnancy, like increased incidence of the preeclampsia, like pregnancy-induced hypertension. If we have a PIH case, we have to be on the high alert that maybe this woman is also having GDM. So high is the risk between these two medical disorders. So when we have a GDM, when we have a big baby, when we have a macrosomic baby, and when you look at the outcome, then the chances of a normal labor or normal vaginal delivery is reduced. The incidence of C-section rates are high because we are worried about the problem which can happen with a macrosomic baby. We are worried about shoulder dystocias. So we are worried about the outcome of a normal vaginal delivery in big babies. So naturally the cesarean section rates are very high. And this also adds to the burden of cesarean section in the country. So when we are looking at trying to optimize the vaginal delivery rates, we would definitely like to contain and reduce the incidence of gestational diabetes mellitus in our women. So we also have heard about all this, why this, especially the GDM is happening in our women. We have heard about those so many hypotheses, the Bacchus hypothesis, and probably maybe the IUGR status of the mother now. Maybe they are more prone to have GDM, and in the bargain, the fetus in utero may also be affected with this GDM, and probably the outcome of that fetus who was exposed to the GDM in the mother, they also have high incidence of having diabetes in later life. So the health of the next generation is affected. The health burden on the country is affected. So these are all the points which we have to ponder. So not only as obstetricians, as healthcare providers in the country, it's definitely a responsibility on all of us to see how we can reduce the incidence of GDM in our population. So when we try to pick up the GDM, or better still, we try to prevent GDM, the outcome is much better. We may be able to have more healthier offspring. So the lesser incidence of diabetes in these babies when they grow up. And what about the mothers who have had GDM? They also have a risk of developing diabetes in the later part of their life. So all these can be reduced if we can find out how we can bring about prevention of this big malady. So that's what we need to focus on. Are there some measures? What are the preventive measures? Of course, we find nowadays like obesity is increasing. So obesity is also contributing to this GDM. So prevention, maybe we can advise our young girls right from the adolescent stage. We find a lot of PCOS. We find obesity increasing in our teenage girls. So if we can reduce this obesity and if we reduce this PCOS burden, probably we'll be able to reduce the incidence of GDM in our population. And we have a better outcome, and that will go in a long way to having better babies, more healthier babies, and lesser chances of developing diabetes in the later life of the mother and the baby.